Okay. As you know, hepatocellular adenoma is a benign tumor. It's very rare. It is confirmed in non-female and oral contraception. I have to conduct for hepatocellular adenoma there is really true history. Since the diagnosis until 2003, and you will see after 2003 many advances have been made on the management of the disease. Before this that, one diagnosis was on radiology and histology. We have only one entity, hepatocellular adenoma. We know that this tumor is a risk of bleeding in malignancy. For that reason, when diagnosis was made, resection was indicated for test of the size. And in patient with multiple hepatocellular adenoma, know that it was noted that they were at higher risk of complication. For that reason, for some patient, liver transplantation can be discussed. But all this was before 2003. Since 2003, many advances have been made in the clinical comprehension of the disease, in the radiological classification, in the histological classification. I will talk about the new recent histological classification. I will talk about the risk factor for complication, and of course about treatment. If we can,
Los colaboré con la luz aquí, el reflector.
Okay. Otherwise, no problem. It's okay. The first one it is that we have a changing trend in the presentation of hepatocellular adenoma. More and more hepatocellular adenoma are observed in obese patients and patients with steatohepatitis in men with steatohepatitis are less and less observed in with oral contraceptives. Very good, thank you. And more multiple, you can see on the CT scan a steatotic liver patient with hepatocellular adenoma, the same very obese patient with multiple hepatocellular adenoma. On the imaging, there is two subgroups of hepatocellular adenoma. The first one is the most frequent one, inflammatory one. You can see on the arterial phase there is enhancement of the lesion. On the delayed phase, there is no washout of the tumor. This is the inflammatory type. The second one is the steatotic hepatocellular adenoma. We can see it is on MRI. On the CT scan, we have adenoma, but it is mainly steatotic. And the third type, the classic one, we have a lesion, hypervascular lesion on the arterial phase, and there is washout on the delayed phase, like hepatocellular carcinoma, and this is the classic or unclassified hepatocellular carcinoma. When we go to the histology, we have four subgroups. The first one is the inflammatory hepatocellular adenoma. This is the most frequent one. It is observed mainly in obese patients taking oral contraception. If we look to some biological tests, we can see some elevated inflammatory marker like CRP level. In this subgroup, beta-catenin can be mutated. The second one is HLF1 mutated. This is the second one. In general, adenoma are small size, most frequently encountered in women. This type of adenoma can be encountered in patients with moderate diabetes. We can encounter multiple forms. The third histological subtype is the beta-catenin mutated. It's observed between 10 to 15% of cases. We know that we have activation of beta-catenin pathway. It is mainly observed in males. On general, hepatocellular adenoma are large. We can have cytological abnormalities, and we can conclude that this subgroup is at risk of malignancy. In about 10% of cases, none of this mutation could be observed for histological subtype. If we know that there is two complications of hepatocellular adenoma. The first one is the bleeding. Bleeding is observed in between about 25% of cases. If we look to the risk factor, the main risk factor is the size. Hepatocellular adenoma is mainly observed in large lesion. Of course, we can have bleeding in small lesion, but it's very rare. Some patients, we can have some focal bleeding in the tumor. The second risk factor is inflammatory hepatocellular adenoma. In our experience, but not yet published, bleeding is much more frequent in female than in male. In this study from Netherlands, they analyzed the risk factor of bleeding, and they found that location on the left level, exophytic lesion, and if we see some peripheral artery, these three elements were risk factor for bleeding. But of course, the most important factor is the size. If we look to the malignancy, risk factor for malignancy are the same, are the size, but for malignancy we can go even more than 8 cm. Of course, we can observe some cases of degeneration in HCC less than 5 cm, but it is exceptional, it is very rare. Which is very important is the gender. In male, the risk of degeneration is about 50%, in female only 4%. The classic radiological presentation form is at risk of malignancy, and of course, beta-catenin mutated. We know that patients who have this mutation are at risk of malignancy, and the risk is about 20% of cases. If we look to the risk of complication according to the histological subgroup, we have the inflammatory subgroup, the steatotic, and the classic. If we look to the malignancy and the bleeding, but we can conclude, this is from our study, we can conclude that the steatotic hepatocellular adenoma, we can observe some bleeding, but in our experience we don't have degeneration, very low risk of complication. Inflammatory one are at risk of bleeding, and the classic or unclassified are at risk of bleeding in malignancy. What about adenomatosis? Adenomatosis is not necessarily a different disease. In more than 50% of patients, we can have multiple adenoma, 2, 3, or more than 10. And we know that the classic adenoma was defined as patients who had more than 10 adenoma. And when we look to our experience, when we compare between patients who have single adenoma, numerous between 2 and 10, and adenomatosis, there is no difference. But adenomatosis were more frequently observed in obese patients. The large tumor was, the size of the large tumor was lower in patients with adenomatosis. Microadenoma are more frequently observed with patients with adenomatosis, and the majority of patients had steatotic adenoma. This is mean patients with multiple adenoma are at lower risk of complications. The same. In fact, even if we have multiple hepatocellular adenoma, the risk is not related, the risk of complication is not related to the size, it's related to the size and not to the number. The same, this is in our experience. Patient with single numerous and adenomatosis, if we look to the risk of bleeding malignancy, there was no significant difference between the three subgroups. And there is many other authors to confirm that even if we have multiple hepatocellular adenoma, this does not increase the risk of bleeding. This is mean we should treat only the big one, and the small one we can only observe. What about the management? First, oral contraception. In some cases, when we have diagnosis, there is the patient is already, oral contraception is already stopped, but when we have diagnosis, we should stop oral contraception. We should wait classically for 6 months, but more and more, we can wait for 1 year or even 2 years in order to have some decrease. Of course, regression can be observed. This is patient had multiple hepatocellular adenoma. We stopped oral contraception, and we see 2 years after regression of hepatocellular adenoma. But of course, long-term workup is not obligatory. If the patient, the woman need the treatment for gynecological indication, it is not an absolute contraindication. What about the obesity? As I mentioned, more and more we have a patient with hepatocellular adenoma and obesity. In our experience, this 20-year female, she was not taking oral contraception very obese admission. This patient was sent to our department for bleeding hepatocellular adenoma with multiple cellular. It was sent for liver transplantation. And we managed it with weight loss, only with weight loss. And we can see 6 months after there is decrease in the weight of the patient. In the same time, we have decrease in the size of hepatocellular adenoma. And 2 years later, and really I see the patient on the consultation 2 months ago. She had surgery, obesity surgery, and there is nearly complete disappearance of hepatocellular adenoma. What about the management of non-complicated hepatocellular adenoma? As we mentioned, in men, the risk of disease is very high, about 50%. For that reason, when diagnosis is done, resection should be done whatever the size. In female, if the hepatocellular adenoma is less than 5 cm, we can only observe the patient. And if it is more than 5 cm, in this case, we should treat. What kind of treatment? In our experience, this patient had multiple hepatocellular adenoma. We resect only the large one on the right liver, the big one on the left liver. But even if, what is the natural history of this adenoma on the left liver? According to our experience in many other authors, we can observe recurrence or progression in only 50% of cases. In about 10% if we can have regression, because if we wait for the oral contraception withdrawal, we can have on the long term a significant effect. But the risk of complication is very rare. It is very rare to have complication in patient operated for hepatocellular adenoma and in home they observe for remnant adenoma on the remnant liver. For that reason, it is still a place for liver transplantation. The same, this patient had large adenoma on the right liver. There is a small one on the left liver. We only resect the large one on the right liver, and 10 years after there is really stability with very small increase in the size of hepatocellular adenoma. And of course, after we should follow up the patient. It is not very complicated. We can do yearly imaging study by CT scan, MRI, or ultrasound, because if you have the histological subtype, if the patient is not very obese, we can do only ultrasound. We can do it once per year for 5 years, and if it is still stable, in this case, we can do every 2 years for the 5 years. Because we know after the age of for the menopause, we know that it is very rare to observe some changes, and follow-up can be interrupted or very spaced every 5 years after this period. The indication for liver transplantation, of course, men with multiple hepatocellular adenoma. We know that men are at risk of malignancy. If we have multiple adenoma, it is not possible to resect all adenoma. It is indication for liver transplantation, except in patients with glycogenosis, because patients with glycogenosis are at low risk of malignancy. Patients with symptomatic glycogenosis is at risk of transplantation. And of course, in some rare cases, we can have hepatocellular adenoma with some agenesis or portal. This patient had a portocaval shunt with large hepatocellular adenoma. It could be an indication because liver resection, it could be difficult or complicated in this context. The laparoscopic approach is an excellent indication. This is a French study to compare between the laparoscopic and open approach. As usual with the laparoscopic approach, we had reduced blood loss and shorter hospital stay, but of course we do not compare the same patient. Only one limit for the laparoscopic approach. You see this is the specimen. This is in some patients, the adenoma has the same aspect as the normal liver, especially if the liver is steatotic. In some patients, it could be difficult to differentiate between the normal liver and the adenoma. In some patients, we can do incomplete resection. Embolization of non-hemorrhagic hepatocellular adenoma. There is new data data are limited. We can do it in patient with small adenoma, patient with we can do it in patient with small adenoma with multiple one. In our experience, we have less than 10 patients and we don't have a favorable result. In our experience, we don't have very good result from after embolization of non-hemorrhagic hepatocellular adenoma. What about ablation? It could be, why not, in patient with 3 to 4 centimeter, and for me the best indication if we have it during pregnancy. If we diagnose hepatocellular adenoma in patient during pregnancy, in order to avoid surgery, I think it could be a very good indication to do it in this situation. Pregnancy is not contraindicated. If we have adenoma more than 5 centimeters, we can treat before any kind of treatment. If it is less than 5 centimeters, we can allow pregnancy is allowed, but we can observe the patient with ultrasound every 2 to 3 months. We can have some progression of hepatocellular adenoma between 13 to 24%, but in our experience, and even in another experience from Netherlands, there is no need to interrupt pregnancy in order to avoid complication, and we don't have bleeding complication in pregnant patient with hepatocellular adenoma. What about the management of complicated hepatocellular adenoma? What about malignancy? As you know, it is very difficult to do the diagnosis of malignancy before surgery. If you have the diagnosis before surgery, in this case, I think you should treat like hepatocellular adenoma by anatomical or non-anatomical liver resection. But in our experience in general, after resection, degenerated hepatocellular adenoma are well differentiated. There is no satellite nodule, there is no vascular invasion. For that reason, if we made a diagnosis after resection, should we do resection or not? It depends. But I think if it is the resection really was very peripheral and incomplete, we know that the patient are young, the normal is healthy, I think it could be, I will preconize re-resection in order to remove a small part of the liver. What about the treatment of bleeding? We know that embolization becomes the standard for the treatment of complicated hemorrhagic hepatocellular adenoma. We know that hemodynamic instability is very rare, or the patient are rapidly stabilized. Really, the indication for urgent surgery become very rare. This is patient with hemorrhagic hepatocellular adenoma. We treat by embolization, and this is 4 months after we have complete necrosis. A few years ago, we operated this patient, but now if we have complete necrosis, we observe only the patient, and there is no need to operate. The adenoma is completely necrosed. In our experience, when we operate to patient operated urgently with delayed resection and non-operated, of course, patient operated urgently need more transfusion, more large incision, and if we look to the complete necrosis, we don't have any necrosis in the patient operated urgently. 30% of delayed resection we have complete necrosis, and 43% non-operated have complete necrosis after embolization and non-surgical management. With this new surgical management strategy, this is mean weight embolization. Surgery can be avoided in 40% of patients with hemorrhagic hepatocellular adenoma. In our experience, when we look to the risk factor for complete necrosis, we have 10 patients with complete necrosis, 39 without complete necrosis, and we see that the patient who had embolization had more tendency to have complete necrosis. Patient who had large hematoma adhesion, and especially before resection, if you have only cystic lesion without any tisular compound, this is mean that the adenoma is completely necrosed and there is no need to operate your patient. What about the histologic management according to the histologic classification? We know the histologic classification is an excellent advancement on the comprehension of the disease, but it is not easy not only for the surgeon, even for pathologists, it's very complicated. The clinical application we don't know, because since 10 years we know that beta-catenin was at risk of malignancy, but now we know from this recent paper that there is 3 mutations for beta-catenin and not only 1 mutation on exon 3 is at high risk of malignancy, but those in exon 7 and 8 at low risk of malignancy. It's not very easy. And this is the new classification. This paper was recently published in Gastroenterology. This is a French metacentric study. As I mentioned in the earlier part of my presentation, in 10% of patients we have unclassified hepatocellular adenoma. They analyzed more than 500 resected adenoma, and they found this activation of sonic heterotope mutation in 4% of patients, and this was associated with obesity and bleeding. And now we know that for beta-catenin we have 3 mutations, and with this new mutation we have 8 histological subtypes of hepatocellular adenoma. This is very important. This patient was sent in 2004 to our department for liver transplantation. We resect, it was in the early of the comprehension of the histological classification. We resect only the adenoma of segment 4. In histology, it was a steatotic subtype. You know that it is at lower risk of complication. And 10 years after, the patient had really complete stability. In the patient, in this case, we avoid liver transplantation in this patient. To conclude, I think in some patients we should do biopsy, but biopsy is not to confirm the diagnosis of adenoma, but mainly for subtyping. If we have inflammatory adenoma, unclassified, beta-catenin or sonic heterotope, in more than 5 centimeters, we should resect. Less than 5 centimeters, because the question, if we have less than 5 centimeters and beta-catenin or the sonic heterotope mutation, should we resect or observe? In our experience, we still based our decision on clinical data, decided the judge. This means even if we have hepatocellular adenoma less than 5 centimeters and beta-catenin, we observe. On the other hand, patient with steatotic hepatocellular adenoma, we can observe, even if you have some patient with large adenoma more than 5 centimeters, and if the resection is difficult, we can observe. Like this patient, this is a young 18 or 20 years female patient, had large steatotic hepatocellular adenoma of 6 centimeters. I observed this patient since 3 years and really have relative stability with the disease. There is no need to do very complicated liver resection in young female with steatotic hepatocellular adenoma. To conclude, risk factors for complication are well established according to clinical and histological data. Steatotic hepatocellular adenoma are at lower risk of complication. Multiple hepatocellular adenoma should be treated according to the size and not the number. Even if you have 20 adenoma, should only resect the big one. Indication to treatment is still based on the clinical and histological data. We should treat the underlying risk factor, oral contraception, and obesity, and other factors. In women, more than 5 centimeters, we should be treated. But as I mentioned, if we have women with more than 5 centimeters but difficult resection, in this case, we can observe. But even if we have beta-catenin mutated, but less than 5 centimeters, the same in our experience, we still observe. In men, whatever the size, we should resect because the risk of malignancy is very high, and embolization should be the first option for hemorrhagic hepatocellular adenoma, and surgery can be avoided. If on the imaging study we have complete necrosis, there is no need to treat because we have spontaneous remission and from the hepatocellular adenoma. Thank you for your attention.